Hey everyone, my name's Joe Arminger. I'm one of the PGY1 pharmacy residents. I was there with Dr. Caroline Wells a few weeks ago teaching you guys about depression. So today we're going to be talking about pain management. A couple objectives. We're going to review the different types of pain, identify the appropriate steps and agents for the treatment of pain, and then recognize potential side effects and monitoring parameters with the various treatment options. So what is pain? It is subjective experience of harm in a part of one's body. So emphasis on subjective. Pain is never an objective measure. What is a 2 to 1 person may be a 10 to someone else. It usually results in the release of histamine, bradykinin, substance P, or other pain-related substances. These tend to travel through the ascending, slow-firing neurons of the spinal cord, where it registers in the thalamus. If you guys remember your AMP, these are unmyelinated or demyelinated neurons, so they are slower firing. The signal is fine-tuned in the CNS with other neurotransmitters, so GABA, norepinephrine, serotonin, NMDA, and then these interact with opioid receptors depending. And next we have our types of pain. So there's two overarching categories. There's nociceptive pain, and then there's neuropathic pain. So nociceptive pain is broken down further into somatic, visceral, and inflammatory pain. Somatic pain is well localized, it's intermittent or constant, usually kind of an aching, gnawing, throbbing, or cramping pain. So think, you stub your toe. Then you have your visceral pain, and this is mediated by discrete nociceptors of the cardiovascular, respiratory, GI, and genitourinary symptoms. So this is usually described as kind of a deep squeezing or colicky pain. So visceral being the viscera, being the things around the organs. So think visceral pain, think organ type pain. And then we have our inflammatory pain, and this usually results from the release of cytokines and infiltration of immune cells. So if you've ever burned yourself, if you've ever been out in the sun too long, and sunscreen doesn't work for you like it doesn't work for me, maybe you've had some pretty bad sunburn, that can become inflamed, and that is kind of that inflammatory pain that you're talking about. And then finally, again, we have our neuropathic pain. So this is spontaneous neural activity. It can actually be measured directly at the thalamus, where the pain signal is ultimately directed to. It's described as burning, squeezing, or shock-like pain. So think of this as those pain receptors in the brain being stimulated full on. You'll see this in certain disease states, MS being one of them, where they describe kind of this burning, shooting pain. So another way we can describe pain is based off of duration. So we can have our acute pain or our chronic pain. So acute pain usually lasts up to weeks or months. There's an obvious cause, and it's a protective response to injury. So what I mean by this is that when you stub your toe or you burn yourself, something like that, you immediately pull away. Well, the reason you pull away is because you're in pain, and you're in pain because your body's trying to tell you, hey, if you keep doing this, you're going to cause some real harm. So acute pain is actually a good thing. It tells us that we need to stop whatever it is we're doing. It begins in short proximity to the injury. So if you've ever broken a bone, you'll know exactly what this means. As soon as you break it, it hurts. And it improves with healing. So kind of like that broken bone, the more time it has to heal, the better the pain is. So, that's a good sign. And then we have our chronic pain. And so this is generally something lasting at least 3 to 6 months, usually longer. There's an unknown cause. It's not protective. So in other words, we don't know why they're in pain. They shouldn't be in pain. It's not really doing anything. The body's telling you that, hey, you need to step away from something that you can't step away from because you're not actually in any danger. And it does tend to worsen with time. It also doesn't respond that well to opioids. So characteristics of chronic and acute pain. So, in general, we kind of went over this, but here's a nice little chart to review. So relief of pain is always highly desirable. Nobody wants to be in pain, right? Dependence on the agents, especially opioids, is very unusual with acute pain, but remember that chronic pain tends to get worse, so people are going to become dependent on it because one, they're on it for a long time, and two, it becomes worse. So they become more dependent on it as time goes on so that they can function at the same level that maybe they did, a few months prior when they, had just started experiencing this chronic pain. Psychological, so you really don't see any psychological effects with acute pain, but with chronic pain, it's a major problem. Think about being in pain all the time. We talked about depression earlier. I mean, this is something that is really it's really limiting for patients. If somebody's in a lot of pain all the time, they can't function properly. Well, now you have issues other than just they can't function. Now they start to think, well, I can't work, I can't spend time with my family, I can't do the things I used to do. And so you really need to be careful with these patients and their mental state. So the cause, organic, is usually common with acute, but chronic pain, it's often not. And then environmental family involvement is usually insignificant with acute pain, but kind of similar to that psychological problem. This is kind of a significant problem because of that psychological problem. And then insomnia, you rarely ever wake up from an acute event that causes pain. But with chronic pain, again, you're just in pain all the time. It worsens. Your drugs tend to stop working after a period of time. And then your treatment goal with pain, with acute pain, is always curative because remember, you're going to be healing. But with chronic pain, you may never get rid of that pain. And so it's more just rehabilitation, teaching them how to live with it. So assessments, we have a few of them. So this is the first one. This is the PQRSTA. And we really just kind of, assess where the pain is, what type of pain it is, how bad is it, when did it start, is it causing anything else? And then we have our next one, and this is what we like to call a Likert scale, which is basically, it's a subjective 0 to 1 or 0 to 10. Where do you fall on here? And again, this is subjective, so what is a 10 for one person may be a 2 for someone else. This is really true in acute pain, where somebody who's been living with, pain that somebody who hasn't lived with pain would call a 10, they might call it a 2 or a 3. And then you have your Wong-Baker phases, and anybody that's ever been to a pediatrician remembers these, and it's just another subjective way to measure pain. So I want to talk about terminology. There's tolerance, physical dependence, and addiction. And just kind of keep these in the back of your mind. There's another slide set we're going to go through talking about this and about, substance abuse. But I do kind of want to give you a little introduction before we get into any of the drugs. So tolerance is basically requiring increased doses to maintain efficacy. This is, again, more of an issue in chronic pain because, pain is getting worse. Then we have our physical dependence, so starts where withdrawal symptoms occur if the drug is discontinued, patients on high enough doses, if they can't be without their medication, otherwise, they're just in so much pain it's refractory, they become dependent on it. And then addiction is a psychological dependence by compulsive drug use. This is kind of a step beyond physical dependence where they are, doing whatever they can to get a hold of the drug. They ultimately kind of become desperate. So in the treatment of pain, we always stress our non-pharmacologic treatments first. So a couple of these, this list is not all inclusive, but a couple good ones are always bed rest, especially for acute pain. You need to rest, you need to stay off it. Stress reduction. Stress reduction is a good one, particularly for chronic pain, because stress can exacerbate pain. Sleep hygiene, good for both of them. A TENS unit, so you can actually buy these in stores and they just apply direct nerve stimulation. It's kind of like a low-level shock, and it has been shown to improve pain. Heat, again, good with all types of pain really, except for burns. Exercise, because exercise releases endorphins. It's also been shown to have effect on other neurotransmitters. And then psychological intervention. So there's something called biofeedback. So patients that have chronic pain may have kind of this therapy. They can have cognitive behavioral therapy, things like that, to teach them how to deal with it. And then educating your patients on the appropriate use and signs and symptoms to look out for in case of addiction or even side effects. So whenever we talk about pain, our first step are always non-opiates. All right, always. And I can't stress this enough. Opiates are good for a certain type of pain, i.e., they are good for acute pain, and they have a role in chronic cancer-associated pain. They do not have a very good role in chronic pain. So acetaminophen is our classic drug. It's the first one. It's good for mild to moderate non-inflammatory pain. So we don't actually know how it works. Some of the theories, so it does inhibit prostaglandin production in the central nervous system and periphery, blocks pain impulse generation, acts on the hypothalamus. Tylenol is a great drug if you have a fever. In fact, there is some data out there that it's actually better for fevers than NSAIDs. The things you have to look out for: hepatotoxicity. So, you have to be careful above 4 grams per day in the general public. If they're older patients, you want to limit them to 3 grams per day. And if they're on warfarin or Coumadin, you want to limit them to 2 grams per day because there is an interaction between them. And then if you have a history of alcoholism, you want to stay away from Tylenol. So in general, this is dosed every 4 to 6 hours. Again, this is good for general pain. It's not good for musculoskeletal pain. It's not good for pain with an inflammatory component. And the nice thing about acetaminophen, it can be used in pregnant women. You don't have any real side effects outside of that hepatotoxicity, but that hepatotoxicity is very real, so we do try to limit to 4 grams per day unless there's an indication to limit to a lower dose. So that's 2 grams for warfarin, 3 grams for older patients. Probably just avoid if there's any hepatic dysfunction or if they have alcoholism. So our next class of drug are the non-steroidal anti-inflammatory drugs. These are anti-inflammatory. What they do is in the name. They are good for pain and they're good for fevers. So how these work, they work by inhibiting cyclooxygenase enzymes. So in our body we have cyclooxygenase that converts arachidonic acid into different prostaglandins, or basically different hormones, if you will. But what they do is dependent on which enzyme. So you can have COX-1 or you can have COX-2, and with NSAIDs we can have COX non-specific, we can have COX-1 specific, and we can have COX-2 specific. And we'll kind of get into that in a little bit. So the first one is aspirin. So aspirin is COX-1 specific. It inhibits platelet aggregation at lower doses, and at higher doses it actually loses that selectivity and it can bind to COX-2, and COX-2 in general is the one that forms the prostaglandins responsible for pain. So of course with aspirin you need a higher dose if you want pain management. And so this is 325 to 1,000 milligrams every 4 to 6 hours. You want to keep this at 4 grams per day. Contraindications. So you want to keep this away from kids and adolescents, less than 15 years old, because you're worried about something called Rye syndrome. And I'll let you look that up in your own time simply because this is such a long slide deck. And So you also want to limit its use in hemophilia, hemorrhagic states, acute alcoholism, liver, kidney disease, so that hemophilia and hemorrhagic states. So remember, at lower doses, i.e. 81 to 162 milligrams, you're inhibiting platelet aggregation. And so, of course, if you have somebody on, a gram every 4 to 6 hours, then you are essentially inhibiting their platelet aggregation, and they're going to have bleeding, or they're going to be at a higher risk of bleeding, rather. So side effects: gastritis, bleeding, renal toxicity, Reye syndrome, and it can also exacerbate asthma. So just kind of keep all that in mind. Now we have a class of NSAIDs. So aspirin is kind of an NSAID, but we don't usually lump it in with the rest of them. NSAIDs specifically, when we use that term, we're talking about things that treat pain. So we have our common non-selective, so think diclofenac, atodolac, indomethacin. This is where ibuprofen and Aleve and meloxicam are here. And then we have we have some other ones that you really don't see that much. Flurbiprofen you may see a little bit, ketoprofen you will, oxyprozin you may, difluzinil you may, but not so much. And then we have our COX-2 inhibitors. So there's only one on the market, and that is Celebrex. So the theory being that if you give somebody Celebrex, you don't have kind of the GI issues that you do with aspirin, you don't have the bleeding risk that you do with aspirin, but it turns out that there may be some impact on cardiovascular health because, long story short, that that COX-1 enzyme that causes platelet aggregation that's inhibited by aspirin, there's another mechanism by which COX-2 works that can actually increase your risk of heart disease, and we're not going to go into that. Just keep in mind that there may be some cardiotoxicity with all of these drugs because they all they all inhibit COX-2. So major side effects. The number one side effect with all NSAIDs is GI bleeding. Because they are local irritants, they are acidic, you see a lot of issues with these. And so the solution is really, there's a couple different ones. Theoretically, again, you have this COX-2 selective inhibitor, that Celebrex. Yes, it works like that, but again, you still may have a risk of heart disease, cardiovascular side effects, not heart disease. What we do in general is we put people on either H2RA, so H2 antagonist, so Pepcid, famotidine, ranitidine, and then the other one is misoprostol. So there's something called Arthritek that has misoprostol in it, and it may or may not work. You also have to avoid this in pregnant women because it can induce contractions. Cardiovascular events, so this is what we're talking about: increased risk of thrombotic events, including fatal MI and stroke, and this is especially seen with the COX-2 selective inhibitors. There is some data out there to show that the risk is lowest with naproxen or Aleve. And then we have our central nervous system effects, so drowsiness, dizziness, blurred vision. You can also see some hypertension, some edema with these drugs simply because of how they work. So here's some dose ranges here. I'm not going to read all this to you guys. This is for your reference. It is a good reference, so I would hang on to this. So onset, for the most part, you see the effects start to work within an hour. Your peak is 2 to 3 hours. They last about 3 to 4 hours. And they're usually available by mouth or by rectal, so suppository. There are a couple that are actually IV. I'm thinking ketorolac or Toradol, and then acetaminophen is available as an IV. Very expensive. Stay away from it. Those of you that are outpatient, which I understand most of you will be, you will never see it, and thank goodness, because an equivalent dose of Tylenol PO is, somewhere around 10 cents, 20 cents. A dose of IV Tylenol is, somewhere around $100. It's expensive. So neat little fact. A lot of people will have this debate between ibuprofen and naproxen. The benefit of ibuprofen is that it has a shorter time to peak, i.e. it starts working quicker, but it doesn't last as long. So it's usually given every 6 to 8 hours. Every 8 hours is what you'll see mostly. I know this says 4 to 6. It depends on if you're dosing it 200 to 400 milligrams or 400 to 800 milligrams. At lower doses, you really don't see as much of an anti-inflammatory effect. It really takes the higher doses for you to get that anti-inflammatory effect, but it does work. All of these work for pain at lower doses. Similarly, naproxen works for pain at lower doses, and at higher doses you get more of an anti-inflammatory effect. Now, naproxen actually has a longer time to peak. It takes longer to start working, but it does last longer, so you typically see it lasting about 8 to 12 hours, whereas ibuprofen is much shorter and, again, dose dependent. So now I want to talk about opioids. And so let's talk about what these are. These are a derivative of the poppy plant, and so they were refined. They were refined many hundreds of years ago, and they were used for pain. Brief little history. It was actually used as recently as 200 years ago, maybe even a little sooner than that. Something called laudanum that was used for, various things. I'll let you guys look that up if you're curious. Then we have our opioid analgesics and how they're broken down. So our natural ones that we see most often are morphine and codeine. Codeine will actually it's metabolized into morphine, and that'll be relevant a little later. And then we have our semi-synthetic ones, so our oxycodone, oxymorphone. Oxymorphone is actually no longer available, but patients may still ask for it. It's called Opana. And then we have our hydrocodone or hydromorphone. So hydrocodone is not available by itself. It's always available bundled with Tylenol and with ibuprofen. And then hydromorphone is available by itself. It's called Dilaudid. And next we have our full-on synthetic ones. We have fentanyl, methadone, and meperidine, of which we see fentanyl the most. Methadone and meperidine are kind of reserved for their own little niche markets. So our analgesics, so it's morphine is the gold standard. We compare all other opiates to morphine. All of these come with various routes of administration. Most of them have a PO and an IV. Some of them have a suppository. Some of them have a transdermal patch. And then we have our short versus long-acting formulations. So you can have oxycodone, which is short-acting, or you can have OxyContin, which is long-acting. And then there's no ceiling analgesic effect. In other words, you can keep pushing the dose of opiates. We'll see why that's a bad thing. You see some of that right here in this high potential for drug dependence, but there are other reasons we want to stay away from it. And then there are different opioid receptors, of which the one that is associated with pain relief is called the mu opioid receptor. So in general, with these, we want to start low and go slow. So let's start with morphine. Next, we have our combination product, oxycodone, hydrocodone, we have our oxycodone and our hydrocodone, of which oxycodone comes as oxycodone or OxyContin. And then hydrocodone only really comes as a combination product. Again, this is your Vicodin, your Lortab, your Norco, your Zydone, and then your oxycodone acetaminophen was the classic, your Endocet, your Percocet, your Roxicet, and there is actually a Percocet liquid that's called Roxicet. Then we have some codeine and combinations. This is Tylenol number 2, 3, and 4. The 2, 3, and 4 are really just correlate to the dosage of codeine in there. And you need to remember with all of these combination products that there is a max dose for Tylenol. And so sometimes what you'll see is, people will be prescribed these opiates, but they'll be on such a high dose that, they go over the max dose of Tylenol, and you have to tell them, you have to keep that in mind when you're writing these prescriptions for them, that you can't go over that max dose. And the other thing to keep in mind, remember what I said about Tylenol. Tylenol is usually the go-to drug for pain relief over the counter. And so if they're taking this with Tylenol, they're probably going to go over their max dose of Tylenol. So side effects with these are no different than anything else. So drowsiness, we have constipation. Opiate-induced constipation is a real thing. Next we have Dilaudid, and Dilaudid is potent stuff. It's our semi-synthetic ketone of morphine. It has a very quick onset of action, very short duration of action though. So it's good if you need immediate pain relief, but you don't want it to go on all day. So this is available as short-acting, immediate release tablets. There's also a long-acting formulation. I believe it's called Zohydro. Parenteral, and we can use this actually in a patient-controlled analgesia pump, so a PCA. So this is where you set a limit, patient presses a button, they get a dose of Dilaudid. It's kind of like a quick bolus dose where they're getting a little bit of Dilaudid continuously, and they just need a little bump to get to control their pain. This is good for patients who cannot tolerate morphine. The reason being because you don't see that histamine release. But there is a higher risk for overdose because this is far more potent than morphine. There's also a high street value in this because, again, it's far more potent than morphine. Fentanyl, this is our other one. And so the only time you will see this outpatient is usually you'll see it in the transdermal form, fentanyl patches. There's also a transmucosal, there's an intranasal, there's a buccal tablet now. There's a ton of formulations. Most of those are going to be extremely refractory chronic pain, but usually they're all indicated in chronic cancer pain. So there's very little histamine relief. It's preferred in the ICU because it's quick on, quick off. You see that here with this onset within minutes. The exception being this patch, which is applied every 72 hours. Things to know about fentanyl in general. So it does take time to work, so you kind of have to overlap with oral opioids. So think some oxycodone for a few days until the fentanyl starts working. You want to make sure that they don't apply heat to the patch because then the patch will release all the fentanyl at once. You want to make sure they don't cut the patch because then the fentanyl will release all at once. And these are, again, reserved for your refractory patients who, they've been on opiates for a long time, they're requiring high doses, and, it's just a pain for them to get it under control because remember, if you're not taking your medication, your pain's not going to be under control. And so, if they're in so much pain or they're so, they're knocked out because of their opiates, they may not remember to take it, and then they're going to be in pain again. And so in general, as a general rule of thumb, it is better to stay on top of pain than ever let it get out of hand because it's much easier to control when you're on top of it. Fentanyl is also kind of difficult to titrate, and it does, again, take about 24 to 48 hours for it to start working. Again, that was the fentanyl patch. So our other opioid analgesics are tramadol and tapentadol. These bind to the opiate receptors, but they're also partially SSRI in nature, or rather SNRI. So they'll inhibit the reuptake of norepinephrine and serotonin. Side effects, same for all of them. Now you see this risk of seizures here. That's because of its effect on the neurotransmitters. This is a Schedule 4, I believe, and it has less potential for drug dependence. You'll see a lot of tramadol. You won't see as much Nucynta. Nucynta's, I think there is a generic, but it's still expensive. Theoretically, less side effects with Nucynta, and it's alternatives to NSAIDs in patients with a risk of GI bleed. Okay, so CDC guideline recommendations. So the first thing to know about these is the goal here is to reduce opioid use. So non-pharm and non-opioid therapy is preferred. We want to establish our treatment goals and evaluate progress. This is particularly important in chronic pain because remember it's chronic, it's probably lifelong. So you want to really stress here that the intent here is not to get rid of all of their pain. It is to control their pain, reduce it as much as possible, and then help them essentially adapt to it. You want to educate on the risk and benefits here. And again, this is true with opioids, but remember that NSAIDs carry their own risk. And then always use immediate release opioids. We don't want to use long-acting opioids if we can avoid them. This kind of the philosophy here is that you're not constantly stimulating the opioid receptor, so you're using the lowest possible dose, and in fact, use the lowest possible dose. So between using immediate release, using the lowest possible dose, you're minimizing the opioid exposure. Again, this is for acute pain mainly. You want to prescribe no longer than needed. Usually less than 3 days is sufficient. Rarely you need more than a week. And then if they are going to be on it long term, you want to reevaluate 1 to 4 weeks after starting. And then if you're going to continue using long term for chronic pain, you're going to reevaluate at least every 3 months. You want to evaluate the risk factors for opioid-related harms and mitigate such risks when possible. Use a urine drug screen. You really want to test before starting opiates and at least annually. This way you're making sure that, one, not only are they clean before they come in, but that they haven't escalated to other drug use. And then you want to avoid concomitant opioids and benzodiazepines. In other words, don't add benzodiazepines on top of opiates because you get an added respiratory depression effect. And then you want to offer and arrange treatments for patients with opioid use disorders. Again, here the goal is to minimize the side effects of long-term opiate use. So, equianalgesic doses. So if you remember, I said that morphine was the gold standard, and in fact it is. So we will get to some problems in some cases, but essentially what I want you to be able to do is convert back and forth between these. So 10 milligrams of IV morphine is equivalent to 30 milligrams of PO morphine. So if you remember from chemistry from high school, we had something called dimensional analysis. You may have seen it in physics as well. Essentially, you're just going to set up a proportion, and that's all dimensional analysis is. You're going to set up a proportion, so 10 milligrams of IV morphine to 30 milligrams of PO morphine is equal to 1.5 milligrams of IV hydromorphone. How many milligrams of PO hydromorphone is that? And in that way you can kind of go back and forth. And so you'll notice here a couple holes in therapy, or a couple holes here. So there's no IV hydrocodone, so that's why there's nothing there. There's no PO fentanyl that will ever convert to. And then oxycodone also doesn't have an IV. And methadone is special. Methadone actually accumulates, and it doesn't really have the effect. Excuse me. It doesn't really have the analgesic effect that other ones do. So you really don't get the quote-unquote high with methadone that you do. It's great for withdrawal. It's great for opiate abuse, but you really won't see it in pain that much. So cross tolerance. So in general, when switching between opioids, it's important to remember that not all opioids have the same potency. And so when this is especially true with tolerance. So when you're continually, let's say you were started on oxycodone, you're on oxycodone for a long time, you decide to switch to Dilaudid. Well, if you use that little chart, you may get, you may get an equal dose. The problem is that, the body sees hydrocodone and it responds in full force to hydrocodone. So hydromorphone, and then all of a sudden this hydromorphone / Dilaudid, it's causing some side effects because essentially you're overdosing them. So when you convert from one opiate to another, consider reducing the calculated dose by 25 to 50%. A good 20 to 25% is a great idea. And then breakthrough pain regimen, they recommend 10 to 15% of total dose. So in other words, if you are giving somebody, let's say, 100 milligrams of oxycodone per day, then you want to give 15 milligrams of that as an immediate release, and you want to give the other 85 milligrams of that as an extended release. And then agents to avoid. So you want to avoid meperidine or Demerol because it causes, it has active metabolites, and these can accumulate and they can cause delirium and seizures. So an easy way to remember this is Demerol is the brand name for meperidine. It's called Demonol, or we call it that to try and be funny, but really that just goes to show you that this drug is not really used often because of the bad side effects associated with it. And codeine isn't really used either. Codeine is much better for cough suppression than it is for pain, but remember that codeine does actually become morphine through metabolism, and so we have issues with this whereby you can either be a poor metabolizer, i.e. you don't make enough morphine and so you don't respond to it as well, or you're an ultra rapid metabolizer and then all of the codeine that you give somebody quickly goes to morphine and you may actually end up overdosing them. Side effects of opiates. So the big ones: CNS, so sedation, hallucinations, euphoria; GI, constipation, opioid-induced constipation; nausea, vomiting; skin, flushing, pruritus; diaphoresis, itching; and then respiratory depression. You can depress the respiratory centers and people will stop breathing. So to manage these side effects, so let's start with constipation first. Opioid-induced constipation delays gastric emptying, slows bowel motility, decreases peristalsis, and increases fluid reabsorption or resorption. And this is the most common side effects. So the way you manage this, you give all patients on opioids a laxative. You also want to give them a bowel softener. So think Colace, or stool softener, I'm sorry. So Colace. And the thing is that if you give somebody a stool softener, yes, you've made their stool softer, but you haven't done anything about this slow bowel motility. And so you really need to give them a stimulant laxative also. So think something like Senna or Bisacodyl. And then side effects continue: nausea and vomiting. You want to tell them to eat or drink slowly. So opiates, especially high dose, can cause upset stomach. So smaller, frequent meals, slower, slower consumption, cooler liquids, things like that. You want to tell them to avoid really greasy, heavy foods or foods that may irritate them. So caffeine, spicy foods, things like that. And then diarrhea, we talked about how this can cause liquid resorption, so that's how this happens. So essentially, opiates cause water to concentrate in the bowels and you get diarrhea, so kind of the converse. You don't see this nearly as much as you do the constipation. For this, you really just want to make sure that, they're practicing good personal hygiene, i.e. they're wiping properly, they're not being too aggressive. If the diarrhea is in excess, then we can use some Imodium. We want to avoid hot or cold food because this can actually cause diarrhea. Avoid caffeine because caffeine is a laxative. And then, if you have diarrhea, anybody that has diarrhea, you always run the risk of dehydration, so you have to replace fluids and electrolytes. And then sedation. So sedation is, if not the most common, secondary or compared to opioid-induced constipation, it's the second most common side effect. And so, in general, we say reduce the dose, we increase the frequency, so you give the drug more often while awake, so they can space it out. They have a little bit more control. You want to, in general, just warn them. So, this sedation side effect, it's worsened if they drink alcohol. They shouldn't be driving or operating heavy machinery. They should be staying at home. This is especially important, because remember, opiates are only really indicated for acute pain and chronic cancer pain, but we will see them in chronic non-cancer pain. But this, it's very important to counsel your patients on this and warn them that they shouldn't be driving. They should have somebody drive for them, especially until they know how the opiates affect them. And then the last is the life-threatening severe side effects of respiratory depression. So risk factors for these. So if you've never been on an opiate before, or you give it to them IV, or you're rapidly increasing the dose, or they already have some sort of baseline lung or kidney dysfunction, then they're at increased risk of this respiratory depression. And so one of the best ways we have to treat this is naloxone or Narcan. North Carolina passed a law that allows a wide distribution of Narcan. And so this is an opioid antagonist. It's used to reverse respiratory depression. So essentially an antagonist, it competes with the opioids for the opioid receptor. All of a sudden the opiates can't bind, and now they no longer have respiratory depression. But keep in mind, they also no longer have analgesia. They no longer have pain control because you've blocked off those receptors as well. And then opioid allergy. So when people say they have an opioid allergy, they're talking about these side effects that aren't really an allergy. The nausea, vomiting, constipation, drowsiness, confusion. They're not real allergies. Anaphylactic reactions are more what we're talking about. So we're talking about bronchospasms, urticaria, and those are the things that we're looking out for a true allergy. And then our chemical classes, so they're all broken down here. I'm not going to go through all of these, but typically if you have an opioid allergy, you're going to be allergic to the same ones in the class. So if you have an allergy to the phenanthrenes, so morphine, you'll have an allergy to hydromorphone, levorphanol, oxycodone, oxymorphone, again, Opana, which is no longer on the market, buprenorphine, which you'll see in Suboxone or Subutex for withdrawal, and so on and so forth. And now we have our adjuvant analgesics. So what are our adjuvant analgesics? So these are drugs with primary indications that are technically not analgesic, but have analgesic activity in some conditions. These are first line for non-cancer pain, chronic non-cancer pain, so think neuropathic pain, MS, fibromyalgia. And you can add these to opioids or non-opioids. We have different classes of adjuvants, and they can be used together. For instance, nortriptyline has been studied with gabapentin. Um, Duloxetine has been studied with gabapentin and pregabalin. Commonly used drug classes, so your antidepressants. Again, we were just talking about it. So nortriptyline, your SNRIs, duloxetine, venlafaxine, and then anticonvulsants, and we have other agents. So the most common ones are tricyclic antidepressants. So amitriptyline, desipramine, and nortriptyline, of which amitriptyline and nortriptyline are the most common. You may remember from depression, we talked about this briefly, amitriptyline tends to have a little better data because it crosses the CNS. We start low, especially in the elderly, because remember, these can cause a lot of drowsiness. We give them at bedtime, and then the effective range is anywhere from 50 to 150, but you kind of have this ceiling effect where doses greater than 100, really you just see more side effects. You want to titrate up gradually, kind of the same as with depression, but this time you're looking to treat pain. You really don't want to use these in somebody with heart disease. We can have some sexual dysfunction, weight gain, nausea and vomiting when started, because remember that serotonin binds to the GI tract, and that's what causes nausea. And then you can have some psychiatric issues due to the anticholinergic effects, which is part of the reason you start low in the elderly. The mechanisms thought to be related to serotonin reuptake inhibition. There is some question about that, but that is the running theory. And then we have our selective norepinephrine reuptake inhibitors, or our serotonin norepinephrine reuptake inhibitors, Cymbalta, milnacipran, and venlafaxine. So class side effects, so sleepiness, headache, dizziness, insomnia, fatigue, nausea, constipation, night sweats. Remember, these affect norepinephrine, which causes fight or flight, so you get night sweats, you may get headache, you may get some hypertension. These do tend to be safer than TCAs with cardiovascular disease. And then dose adjustments, you need to be careful in renal and hepatic dysfunction. So the question is, if the effect of these is thought to be due to serotonin, why are there no SSRIs? And quite honestly, there's no good answer. We just know that SSRIs don't work in pain. They may work a little bit in fibromyalgia, but really the SNRIs are where that's indicated. For milnacipran or Savella, I don't believe it's been shown to be any better than duloxetine or venlafaxine, but it's infinitely more expensive. Remember, with Cymbalta, duloxetine, you get that SNRI component right up front. You get both of those receptors. For venlafaxine, you actually have to get to higher doses. And so you can kind of see that here. I'm not going to go through all. And then Savella, this is FDA approved specifically for fibromyalgia. It's really expensive. It doesn't work any better than Cymbalta, duloxetine. And so you may try it. Your patient may get some benefit from it, but in general, it's not something you see very often due to the price. And then Effexor, our good old antidepressant friend. Remember that minimum effective dose, and so you're looking for the SNRI component here. And then when using these, you just want to be careful for our CYP450 drug interactions. You want to watch out for serotonin syndrome, especially if they're on something like tapentadol, Nucynta, or tramadol, Ultram, which has serotonergic properties. And so, if you have them on tramadol and then you have them on high dose TCA or SNRI, and then let's say you're throwing something else on top of that. Let's say they have an infection and somebody puts them on Zyvox or linezolid. You do run the risk of serotonin syndrome. Monitoring, you want to monitor physical function and pain. And this makes sense. Like, you want to make sure it's working, correct? And then for the analgesic effect, you see that after about a week, but the analgesic effect may increase over time, so may get more benefit over time. Remember, these affect neurotransmitters, and it takes a little while for those neurotransmitters to actually be affected, because we're increasing the hang time, as Dr. Wells put it a few weeks ago. And we want to taper these over 2 weeks to prevent withdrawal, and remember those hepatic and renal dose adjustments. Next, we have gabapentin, gamma-aminobutyric acid. It binds to the alpha-2 delta receptor of the spinal cord, and in that way it modulates pain. And so we start with an initial dose of 100 milligrams in older adults, 300 milligrams in younger adults, because this has side effects: drowsiness, dizziness, fatigue, ataxia. So that ataxia is basically slowing down of the motor skills. And so, you start with a lower dose, and the theory is that starting at a lower dose, you minimize that side effect. The effective dose is anywhere from 1,200 milligrams to 3,600 milligrams divided in it 3 times a day. So the caveat to this is, if they have renal impairment, this is heavily renally eliminated, so you'll have to dose adjust. The best evidence for this is with diabetic neuropathy, postherpetic neuralgia. There's also data with fibromyalgia and chronic neuropathic pain, cancer or non-cancer. And so in general, just be aware that you can use gabapentin. And then we have our products with it. Typically, we have a generic, which is given multiple times a day. There are some once daily products approved. They're expensive. Their FDA approval varies. In general, you're probably just going to use the generic gabapentin. Reserve these for somebody with that Cadillac insurance who wants a once daily option. And then we have pregabalin, which is a far more far more potent form of gabapentin. And so think of pregabalin like gabapentin 2.0. You need lower doses. You're still giving it 3 times a day. You can increase to 300 milligrams a day in 1 week and 450 milligrams a day in 2 to 4 weeks. The max dose is usually 450 is the maximum effective, but the maximum dose in total is 600 milligrams. You just don't really see any effect beyond that 450 milligram daily. Again, much higher bioavailability and potency, but similar side effects. And this is actually a Schedule 5 drug because of the euphoria. Actually, that's right here. So the euphoria with initiation of therapy. Truth be told, you probably see that euphoria with gabapentin as well. 450 milligram dose produced pleasant effects similar to 30 milligrams of diazepam in a study of 15 recreational drug users. There can be some withdrawal symptoms. And then this is approved for fibromyalgia syndrome, FMS, diabetic peripheral neuropathy, and postherpetic neuralgia with neuropathic pain as well. Again, renally dose adjusted. Next, we have our anti-epileptics. So carbamazepine and oxcarbazepine are the two where we have the most data. This carbamazepine specifically for this trigeminal neuralgia. So if you remember again from A&P, the trigeminal nerve is the nerve that if you put your index, middle, and ring finger up against your face, that's the trigeminal nerve. It branches off into 3 phases, and I believe that it is motor and sensory. It's at least sensory. And so you can have trigeminal neuralgia, and it is very painful. You'll also see it used in migraine prophylaxis and neuropathic pain. Things to monitor here, so you want to monitor a complete blood count because you can get aplastic anemia, you can get a rash. There are some cardiovascular side effects, CNS, nausea, and vomiting. Carbamazepine is actually one of the big drug inducers, and so if you induce a drug's metabolism, you lower the serum concentration, unless it's a prodrug, in which case you're increasing the serum concentration. So you just want to be careful. You can also do something called therapeutic drug monitoring, where you check levels on carbamazepine to look for a specific level, specific therapeutic target. Yeah. So you see this, you get some benefit from your alpha-2 antagonist as well, or your alpha-2 agonist. So the alpha-2 receptor in the CNS is actually a negative feedback loop. So essentially it's the body's way of saying, hey, there's too much norepinephrine running around. You need to stop, back off of this. And so when the alpha-2 receptor is bound, then you decrease that fight or flight response. You get more sedation, more hypotension. And so clonidine is the big one. You'll see clonidine actually used in withdrawal as well as hypertension. It's really good for resistant hypertension as long as the patient's compliant. So these have been shown to increase or inhibit the release of substance P from the primary afferent terminal, preventing the release of catecholamines, catecholamines of which norepinephrine is one. And so the side effect with clonidine is hypotension and sedation. Remember, it's a blood pressure medication first. And then tizanidine, which is specifically used in musculoskeletal pain to prevent spasms. It's 4 to 8 milligrams per day. You get sedation, hypotension, and also possibly hepatotoxicity. So be careful with that, especially in conjunction with something like Tylenol, or if they're a heavy drinker, or if they have any sort of other liver dysfunction. So antispastic versus antispasmodic. So our antispastics are baclofen and dantrolene. You won't really see dantrolene. And then somewhere in the middle is tizanidine and diazepam. And then our antispasmodics, remember the short-term ones, Flexeril and methocarbamol, Robaxin. So antispasmodics, they may have benefit in the first 2 to 7 days after injury, especially as an adjunct to rest physical therapy and analgesics for acute low back pain. They're ineffective for spasticity due to multiple sclerosis, stroke, things like that. So not these chronic conditions where we don't know what's going on. We're thinking musculoskeletal pain. Most common side effect, drowsiness, dizziness, and we can take advantage of that sedative property to promote sleep, but you want to caution them about the driving, the fall risk, the use of alcohol. So remember, these are more for acute injuries, and remember, acute injuries are associated with acute pain. Acute pain gets better with rest, so maybe there's some benefit here. These aren't really studied as adjuvants to analgesics, but they're used that way. And then the antispasmodics, so we'll use Flexeril, so 5 milligrams is as effective as 10 milligrams with fewer side effects, so really you don't need to bump to that 10 milligram dose, you can keep it at 5. It does have a TCA structure, so you get some anticholinergic effects here. Then we have Robaxin and carisoprodol or Soma, and this is metabolized to meprobamate. Sorry, it should not be that difficult to pronounce. But this is a C4. And then we have some others, some antispasmodics, so cortisone, I'm sorry. And so we do see some rare hypersensitivity and dermatologic adverse effects. We really don't want to use these long term because it can cause some fatal hepatocellular injury. Metaxalone or scalaxin, nausea, rash, pruritus, and LFT elevations, and then orphanedrine, which you really don't see all that much. It's similar to Benadryl, and it shares many of the same side effects. But you don't see these three used very often anymore. I would say the one that you'll see most is Flexeril, and remember 5 milligrams is as effective as 10 milligrams. Finally, we just have briefly our topical agents. So our non-NSAID topical agents, lidocaine patches, they're great. I love them. I love to tell patients about them because they're over the counter now. It's essentially a topical. It's topical pain relief. It works pretty well. You put the patch on for 12 hours over the spot that's hurting. You take it off for 12 hours. They can put multiple patches, up to 3 on a day. There's minimal systemic absorption, and the thing is that all the data is really with post-herpetic neuralgia. Remember, pain is subjective though, and so if they try it, especially now that it's generic and it works, great. If it doesn't, they're only out about $14. And then we have capsaicin. So this depletes substance P at the nerve endings. Basically it's pepper in a cream, and you need to make your patients aware it does cause some initial burning, but that usually subsides, and it comes as a cream or a patch. You can apply it up to 4 times a day. Best evidence is really with osteoarthritis and post-herpetic neuralgia. It does work though. So that is the end of our pain management slide set. If you have any questions, feel free to email me, and then the addiction PowerPoint will be up shortly. All right, thank you, and we'll see you all in class soon.